Morning. Thanks for inviting us. I'm going to talk about the arthroscopic treatment of jumper's knee, our experience of 10 years. Jumper's knee is an overload syndrome often associated with sport involving jumping, such as volleyball and basketball, but also with sport characterized by rapid and explosive quadricep contraction with acceleration and deceleration, such as running or kicking. Lecter says that a tendon is overloaded when it's stretched from 3 to 8% of this length, and tendon mechanical resistance depends both on the number of the fiber and on its size. This variable from subject to subject and can be influenced by sport activity till 20 years old. After this age, can increase only the strength of the tendon, but not its mechanical qualities. The patellar tendon is an anatomic structure scarcely vascularized. So the increased but a great oxygen consumer. So the increase of function request in addition to dehydration may reduce perfusion and lead to a tendon fragility due to ischemia. The breaking of the bond of the collagen fiber causes microlation that can be repaired or can progress. The progression is described by Blasina in 1973 that described 4 stages, and each clinical stage corresponds to an anatomopathological stage. This is our study that is on press on the American Journal of Sport Medicine. It goes from June 1996 to June 2006. We treated 64 patients for 73 knees. 26 of these patients were classified as Blasina stage 3 and 30 of these patients were stage 2. All patients failed the conservative treatment before surgery. These are the sports in which our patients were engaged. And all patients had anterior knee pain, evocated by the Pudus maneuver. And from lecture we know that the pain is not due to inflammatory phenomena, but to a biochemical action. Furthermore, all patients had increased tendon volume and altered signal of the patellar tendon near the lower part of the patella, both at MRI and ultrasonography. Then talk about the surgical technique. We use the surgical approach, arthroscopic approach, from the anterolateral portal for the arthroscope and the medial superpatellar for the continuous irrigation. Then at this stage, we decide whether mid-patellar portal is necessary to visualize better the off-affect pad, particularly if the latter appear to produce into the joint. Then all portal can be interchanged between arthroscope instrument and irrigation. The anterior compartment is then examined, as you can see in the video. Hypertrophy of the off-affect pad and mucous ligaments are often present, and moderate to severe synovial hypertrophy is always present under the lower part of patella. That's why sometimes we can use a needle to aid to locate the apex of patella. Then the hypertrophic synovial tissue is removed using both arthroscopic shaver and radiofrequency devices. The removal of the tissue allows the visualization of the articular side of the tendon and this insertion to the patella, then and the lower part of the patella. After this careful preparation, we perform abrasion of the patella apex. This is the post-operative program. Then we go from immediate bearing to jogging, immediate weight bearing to jogging after 6-7 weeks and return to sport activity after 9-12 weeks. The average follow-up is 85.7 months, and we have 60 patients for 18 knees with a follow-up longer than 10 years, 35 patients for 41 knees with a follow-up between 5 and 10 years, 13 patients for 14 knees with a follow-up between 5 and 3 years. Preoperative and postoperative evaluation was made with lesion score, IKDC, and VSP. All the scores show a significant improvement after 1 year that remains significantly constant with time. This is the evaluation with lesion score. You see that the evaluation preoperative is poor and fair, but remains significantly improved at 1, 3, 5, and 10 years. The same with evaluation with IKDC score. And with the VSP. We perform VSP from January 98, so we don't have all the patients. We can conclude, say that arthroscopic technique advantage is that it's a less invasive technique, we have better precision, it's an earlier surgery indication, and return to sport activity in short time. Thank you.
Yeah, thanks a lot about the interesting presentation. Are there any questions in the auditorium? If not, I will ask you that, have you been using this radio frequency coagulation at the same time with this procedure or alone?
Radiofrequency device intraoperative.
Intraoperative, but
Yes,
coblation making those small holes like in tendinosis tendons.
No, not for making, just to take
remove
off the hypertrophy of the synovial and the lucus ligament.
Synovectomy devices.
synovectomy.
Yes. Okay.
Yes, we use a lot of treatment before. It was like 4-6 months of not operative treatment, such as NSAID or radiofrequency, laser, TEGA. Or that's the failure of this procedure lead us to surgery.
Okay. Thank you very much. And there's one question. Please use the microphone.
Borski from Switzerland. What was the conservative treatment, or do you have experience with platelet-rich plasma in this condition?
Do you have experience?
Platelet-rich plasma.
Platelet-rich plasma? No, we never used platelet-rich plasma with jumper's knee. Conservative treatment was anti-inflammatory drugs and other anti-inflammatory therapy. No PRP.
Thank you. We will proceed.